so that you understand the difference between the systole, diastole of the heart and the arteries. When the heart goes into systole, it again, as we mentioned, have mentioned again and again, it introduces blood into the aorta or in the arteries, let's say, to generalize this. When it does that, it was resting at its normal diameter. But when systole in the heart happens, the blood is introduced here, these arteries get distended in three directions. One is, two are across their diameter to distend them, and one is that kinetic energy thing which propels the centermost layers of the blood forwards to the towards the arterioles. Okay, I think this is very clear. During diastole of the heart, there is no forward propelling delta P like situation. So what happens is they relax. When they contract on the bolus of blood that was introduced within the systole, so when the driving force has been switched off and the heart goes into relaxation to its own diastole, the diastolic phase of arteries also starts. And during this, the distended arteries, since they have a lot of elastic tissue, they bounce back inwards. And this then propels the blood forwards during the diastole. So very, very crucially, the blood gets distended, the blood distends the arteries and flows forwards during the systolic phase of the artery. And during the diastole phase, when the walls come in, when the walls contract due to elastic recoil of the artery, the blood again also flows in the forward direction. So you have forward motion both in systole and diastole. Now, to jog your brain a bit, let me throw in a curveball here. What if, imagine, what if the arteries were made of steel? Think about it. What if the arteries were made of steel? Now, just make a steel artery, steel, everything from aorta down to the arteriole, just convert it in your mind into steel, i.e. something which is fixed in diameter, okay? Connected to the aortic valve, and now pump the heart, one beat at a time. Now, when the ventricle goes into systole, it introduces that same bolus of blood into the steel aorta. What would happen? Imagine. I'll give you a few seconds. Get those brain juices flowing. What will happen? You will have a spectacular increase in systolic pressure, wouldn't you? Correlated with what happens in arteriosclerosis. What happened here? Well, not steel, but adipose tissue rendered your elastic, nice, expandable, distendable arteries into something which is a bit more rigid, right? And look at the systolic upstroke. So now what I've done is, hypothetically, I've just made them of steel. So they cannot contract, they cannot distend, they are just fixed. So when you now push a bolus of blood in this steel system, it cannot distend. So the systolic pressure during contraction of the blood really goes up during inside the arteries, right? That's the simple bit. Try imagining what happens then. Would there be a diastole in this steel artery? No, sir, there won't be. For that diastole to happen, it should have distended and then contracted. That causes the forward motion during diastole of the arteries. That cannot happen in the steel artery. This is to show you the phenomena of diastole in arteries. So arteries are distendable, they contract, they have a lot of smooth muscle, lots of elastic tissue. When you expand them, they will contract as soon as you minus the driving force. Okay, steel arteries, if they ever exist, cannot contract. Just to complete the sequence of the steel arteries, the blood would come in, and what would happen? It would raise the tension against the steel walls, and then propel the blood to some extent. And then what would happen? Since you cannot have a diastolic component in these hard arteries, the blood would cease to flow during diastole. So it can't even reach the arterioles. Now you understand the pulsatile flow, the role of the elasticity of the arteries, and the diastolic phase of the arteries. What role, what important role it plays in the propagation of blood flow throughout the arterial side of the circuit. If it not were for the diastolic contraction of the blood of the arteries, which would propel the blood forwards during no propelling motion from the heart, the thing would just stop flowing during diastole. Okay, so this is the importance of systolic and diastolic pressure. Um, some bits correlating it to the heart, the systolic pressure of the artery. Now, from now on, whenever I say systolic and diastolic, unless I mention it, it basically means systolic and diastolic phase of the arteries. So systolic pressure basically is under the control of cardiac output. The diastolic pressure is under the control of the arteries themselves. TPR is total peripheral resistance. We have spoken about it in the first lecture. If you haven't taken the first lecture, please first listen to that lecture and then come to this bit, because you won't be able to understand what this is if you haven't really studied that matter. Total peripheral resistance, very briefly, is the total amount of resistance put up by all the arterial tree together. So it's the resistance to blood flow inside the arterial system, mainly exerted by arterioles. So once again, the systolic pressure is controlled by cardiac output. If you have more cardiac output, the systolic pressure would naturally go more up, which will increase. In the diastolic pressure, however, if you increase the total peripheral resistance, you are basically contracting the arteries. This will affect the blood pressure congruently in a negative way. Now, pulse pressure is, we have, I think, exhausted this bit here, systolic and diastolic. Um, this pulse pressure and mean arterial pressure is the feature of the rest of the most of this, actually rest of all of this lecture. We'll be talking about pulse pressure and mean arterial pressure. First, we talk about pulse pressure. As I mentioned to you, when you subtract diastolic from systolic, you get pulse pressure. So 120 minus 80 is 40 mmHg. So 40 mmHg is the average pulse pressure. Systolic pressure is affected by your cardiac output or stroke volume. As you know, it's the same thing. Cardiac output is the output of the heart, the working of the heart per unit time. Stroke volume is the volume of blood that is pumped per beat. So cardiac output and stroke volume can be used interchangeably. Systolic pressure is affected by stroke volume or cardiac output. Diastolic pressure is basically total peripheral resistance. You can also mention compliance, because again, it will take you to the first lecture. Compliance means accommodation of blood in a vessel. Resistance means the opposite, decrease accommodation of blood inside a vessel is called resistance. You increase the resistance, you decrease the compliance. So diastolic pressure is affected by arterial status, whether it is a nice elastic artery which is compliant, low in resistance, or is it a hardened or relatively hardened artery, low in compliance, more in resistance? This means the whole thing, i.e., this whole thing basically determines what the diastolic pressure would be. Okay, these are some of the examples of pulse pressures. A weak and thready. You'll study shock in the end, very briefly, to introduce it, shock basically is an inability of the circulation to provide adequate blood flow throughout the circulation. So everything goes down, all the pressures go down. Obviously, then the wave front that we talked about, the pulse wave, the pulsation, they also, the pressure goes down. So when a person is in shock and you were to take this person's radial pulse, you would feel that the pulse is very weak because the wave fronts are very weak due to, say, loss of blood. There's not enough thrust in the arteries to make a proper pulse. In this person, we call this pulse weak or thready pulse. Thready is just like, it's like a bead of threads hitting against your fingers on the radial artery. So this is how we describe that. In exercise, you have strong pulse. If you exercise, try taking your pulse, you will see that it is bounding, it's hitting your fingers nicely and more than when you are at rest. Then there are clinical scenarios in which one is right here, aortic insufficiency, in which the aortic valve has lost its proper opening and closure. It's flimsy now. During the entire systole of the left ventricle, it's incompetent. So it just flaps around. And this kind of system in the aortic valve generates a collapsing or water hammer pulse. It goes up sharply and drops back sharply as well. It is not like a normal pressure pulse. Again, this can be expanded in your tutorial. So this is basically stuff about pulse pressure. Right at the end, we will be looking at some of the scenarios which involve blood pressure, pulse pressure.